Ma'am, we are live in 3, 2, 1.
Good afternoon, everyone, and welcome to this CME on current management concepts in AUB. This is being hosted by ISPAT along with ICOG. ISPAT, or else the Indian Society for Prenatal Diagnosis and Therapy, is a 34-year-old organization among the first few organizations of prenatal diagnosis in our country. We have a great team of fetal medicine specialists, obstetricians, pediatricians, radiologists, geneticists, biochemists, and the likes. We believe in a team approach, and there is a lot of academic interaction that keeps happening, and we have a lot of academic activities, this being one of them. We are also affiliated to the International Society for Prenatal Diagnosis. This is something which has been done with the help of Dr. Narendra Malhotra under his presidentship. Our founder president, Padma Shri Dr. Rustam Sunawala, has been extremely supportive to us and participates in most of our events and our meetings. I also would like to acknowledge ICOG for giving us credit points for this CME. I would like to thank ICOG Chairperson Dr. Lakshmi Srikhande, Secretary Professor Ashok Kumar, and also thanks to our academic partners for this support. Can I have the next slide, please? So we hereby welcome you and looking forward to an extremely interesting and interactive academic presentation. Aditi, please proceed.
Dr. Sugandha, ma'am, you can start sharing.
So, dear doctors, a very warm welcome to the webinar on current concepts in AUB in association with Zestiva Mankind, wherein we bring esteemed stalwarts from the field of obstetrics and gynecology. But before we move on to scientific agenda of the afternoon, let me take you through the brief journey of Zestiva Mankind in Indian pharma industry. Dear friends, with humble beginning in 1995, Mankind Pharma is today among the top 4 pharma companies with #1 rank in terms of prescription and 4th in terms of top-line revenue. In 2021, Mankind launched its dedicated gynecology division, Zestiva. Zestiva is committed towards innovation and developing new therapies in the fields of ops and gynae. Few important milestones in our journey over last 2.5 decades include our achievement to have leadership position among majority of therapeutic segments by 2008, followed by our entry in export and global market in 2013, and starting US operations in 2017, receiving US FDA approval of manufacturing plant in 2019. In early 2020, Mankind was first in India and second in the world to develop dydrogesterone, and the journey continues with the publication of state-of-art clinical research in hypertension called TELCOM study in American Journal of Cardiology in April 2022 based on latest hypertension guidelines. Later in 2022, we acquired Panaceia's India and Nepal business. The latest milestone in Mankind's journey is launch of DMF API products in India. DMF is submission to US FDA about manufacturing, processing, packaging, and storing of human drugs. It contains factual and complete information on drug products starting from manufacturing, flavor, drug substance, purity of drug, along with the impurity content, material used to prepare drugs, drug excipient, stability of drug, and information about packaging material. Therefore, Mankind has taken this initiative to bring the DMF API products in India at Indian prices. We have a large basket of DMF products, and we are coming up with many more. With these words, I would like to hand over the session to Dr. Saurabh Dani.
Thank you, Sugandha, for the introduction. So now we will take the session forward. And to take the session forward, I would like, Aditi, can you switch on? Yeah. I would like to introduce our convener for today. But before I introduce the convener, I would also like to share a little more about ISPAT. I'm sure you must be wondering where ISPAT comes in AUB. ISPAT has been not only working in the field of prenatal diagnosis, but it takes care of the whole ambit of preconception, post-conception, that is pregnancy and postpartum journey, including the neonatology part also. So we look after women and children in all the age groups, and definitely AUB also falls in one of those categories. And to keep the spirit of ISPAT alive, we have definitely included a topic which is called newborn screening, which caters to the newest trend in neonatal care, which is upcoming in India, but has been having a very strong history. So let me introduce you to our first co-convener and also secretary of ISPAT. So Dr. Manjeet Mehta has been working closely with ISPAT and me from a very long time. And I'm happy that she is a secretary when I'm the president. It makes my job very easy. She's a reproductive geneticist. She has an experience of 32 years of genetics in India and US and UK. She has done PhD in human genetics from Jaslow Hospital. She has 2 PhDs, one from Toronto and one from London. She has advanced training in human genetics at the Yale Center of Advanced Genomics. She's the director of clinical genomics at Live Genomics Lab, Mumbai. And she is an active member in various organizations with special interest in genetic basis of disease and gene expression. And she has several journals and chapters in her name. Thank you, Manjeet, for being the co-convener. Besides this co-convener, we also have another co-convener who is Dr. Pratik Tambe. Unfortunately, because of some urgent situations, he couldn't be present today. We thank him for all the help he has provided in framing this program. I'm sure, Pratik, when you go through this program, you will feel that you have definitely missed it being live. Over to you, Manjeet, to take the program forward.
So we proceed with the first talk, and it is my honor to introduce Dr. Jyoti Bobe to you. She is an obstetrician and gynecologist and the president of the Navi Mumbai OB-GYN Society. Dr. Jyoti has been practicing since 31 years in Navi Mumbai. She is a consultant at Anuja Nursing Home and the president of Navi Mumbai OB-GYN Society. And she's also the consultant at Apollo Hospital, CBD Belapur, and Kokilaben Dhirubhai Ambani Hospital in Kopar Khairne, and IRC Airoli, and Apollo Hospital. Okay, that's repeated. So welcome, Dr. Jyoti.
Thank you very much, madam, for kind invitation. And I would like to go ahead with the session immediately, if it is possible. Dr. Saurabh is taking first session, right?
Chairpersons.
I'm the chairperson, I think.
Yeah. Dr. Varsha is also a chairperson.
Yeah.
So Dr. Varsha is a close friend. She is from BJ Medical College, Pune, and she was previously the organizing secretary for. She was the organizing secretary for NOGS in the year 16-17. She's a vice president of AMOGS from the term 22-23. Past joint secretary of IMA as well as of the Yuva FOGSI in 2014. She's a member of the Breast Committee, Adolescent Committee, FOGSI, and national speaker for Hysteroscopy. She's published various papers in international journals. Dr. Varsha Lahade, welcome to this session. We also are privileged to have with us Dr. Jyoti Saigaonkar, who is the director of Dr. Saigaonkar's hospital. She received the first prize in Dr. Shirin Mehta ji and Dr. D.K. Tang paper presentation She's presented many papers and published many articles in Marathi, English newspapers. And she's been interviewed by Digi Thane, Z News, Aaj Tak, and social media on women's issues. Dr. Jyoti is working actively with NGO, Raising Foundation, and Rotary Inner Wheel Club, educating women on menstrual hygiene and menstrual cups and sex education. Her areas of interest include advanced gynec endoscopy surgeries. She is an IVF consultant. She also does high-risk obstetrics, ultrasound, 3D, and 4D. Welcome, Dr. Jyoti Saigaonkar.
Thank you, Dr. Manjeet. Yeah.
So, Dr. Saurabh Dani is giving the first talk. Our dear President ISPAT of the current term, Dr. Saurabh Dani, is an extremely passionate obstetrician and a very active leader. He is a consultant OBGY at GEM, Namaha, Cloud9, and HCG in Mumbai. He holds a special interest in high-risk pregnancy and also newborn screening. Dr. Saurabh Dani is the current president of the Indian Society for Prenatal Diagnosis and Therapy. He is a coordinator for strategic leads and development with EverHeal, which is a maternity care program which has a holistic approach towards care during pregnancy. Dr. Saurabh Dani is also the past president and also the advisor for the AFG, that's the Association of Fellow Gynecologists in Mumbai. He is a coordinator for the MCGM newborn screening program, which is a topic which is really close to his heart. And let's hear it from you, Dr. Saurabh.
Thank you, Manjeet. It's a privilege to be on this platform and talk about something which I really like to talk about. I hope you can hear me. I'm having little throat issues, but nonetheless, we should be able to go through. Can I start sharing my PPT, Aditi?
Yes, sir.
Okay. So I'm sure you all must be wondering why newborn screening has to be even spoken about to gynecologists. And I think the whole journey starts very much early in the third trimester when the woman is supposed to deliver, and she needs to know what is the next steps going to happen post delivery. And one of the important things that we need to talk about in the immediate postpartum period is newborn screening. So newborn screening, according to me, is a must. It's something that we all need to counsel our patients. We all need to tell them that they should be doing it, because we are living in a country where newborn screening is not mandated by law. I'm sure there are a lot of cities, states, and organizations doing newborn screening, but as a law like we have it in America or some other developed country, it's not part of the law. So we need to understand why is it important and voluntarily take it up so that we can reduce the disease burden in our country. So unlike all the tests that we do, newborn screening is not just a test. Newborn screening has to be treated like a program. The way we talk about pulse polio program or a national TB eradication program or how we do a GDM screening, that's how we have to take it as a program. So when you talk about anything as a program, there is a certain process that we need to follow and we need to understand. So basically, we need to understand which population we are going to screen. So here, the population being all newborns which are born in a certain healthcare facility. So now that could be your small nursing home, it could be a corporate hospital, it could be a municipal hospital, it could be a government hospital, or it could be a district hospital as well. So that's the population. So basically, all newborns born in that population. Then we screen the appropriate group. So we basically find out that which is the babies that fall in that category. So all babies who are alive more than 24 hours, that is the babies that we are going to screen. Then how the screening process has to work, that is also equally important. So the right time, the right process, the right equipments, the right pre-analytical equipments, analytical equipments, and post-analytical strategies. How do you really transport the specimen also? What happens when you have a positive result? What is the action that you take? And how do you take care of the early follow-up and diagnosis? And after that, the clinical management and immediate treatment which has to follow. So when you do all the steps, that is where we call it a program and not just a test. So I have been closely associated with the Mumbai Municipal Corporation newborn screening program. So I will in brief tell you what the program is. So basically our target population was that all the babies who are born in the 4 medical colleges, the municipal medical colleges, that is Sion, Nair, KEM and Cooper. So what we decided is that we screen all the babies for a certain set of disorders. It is thyroid, that is congenital hypothyroidism, CAH, congenital adrenal hyperplasia, G6PD deficiency, and hemoglobinopathies. These are all basically a part of the RUSP, that is Recommended Universal Screening Panel, which is also based on the Wilson and Jasmus criteria, which basically tells us which disorders you should include in screening programs and which you should not. Then the sample was collected after 24 hours of birth via dried blood spot. So basically a heel prick was done and it was collected on a filter paper, and that filter paper is allowed to dry, and hence it is called as a dried blood spot. So the test which were done for TSH, for CH, we did a TSH using fluorescent immunoassay. Same thing, we did 17-OHP for CH, G6PD enzyme semi-quantitative, and HPLC for all the hemoglobin variants. The reports were to be submitted within 96 hours. And then anyone who turns out to be positive has to be counseled as to what are the next steps to be done. And then a further confirmatory test is done. Because this is a screening test, always it is followed by a confirmatory test before you label anybody anything. So you just, on the screening test, you don't label somebody having a certain disease. You always do a confirmatory test. And once the confirmation is done, then handing over to the appropriate doctors for further clinical management. This program started on 13th of September 2019 and it ended on 17th of July 2022. So in that period, totally we screened, so ignore the period on the top, that's little incorrect. The total screened babies were 39,363, of which the incidence of congenital hypothyroidism is 1 in 2,300, CH is 1 in 7,800, G6PD is 1 in 200, and the hemoglobin variance is almost 1 in 75. So if you see a cumulative incidence, it's almost 1 in 50, 1 in 154. So if you look at newborn screening, so what is the population that we were catering to? Can you see the mouse? Okay.
Yes, sir.
Yeah. So this is the only population that we were catering to under the program. That is, if you look at the Indian healthcare situation, Indian healthcare has basically 3 broad categories: central, state, and private. Under the central, you have AIIMS. Okay. Under the state, you have district health services, medical education, and then you have municipal hospitals. So all that we were doing is the 4 municipal hospitals or medical colleges in the municipal corporation. So there is all other population which has not been catered to. Also the private, that is nursing homes, charitable hospitals and corporate, were not touched under the program per se. Not that it must not be happening, it must be definitely happening in private in another different way, but this program was not catering to that. And we need to see a trend, what is happening. So this is one of the report which has recently come out from the corporation. If you see over a period of time, the number of deliveries which are happening in the private sector, the percentages are increasing. And the number of deliveries happen in the public hospitals, the percentage is going down. So according to me, there is a big role the private hospitals and the institutions need to play in seeing that universal screening happens across the board. And that's the reason why I'm here talking about why is it important to do newborn screening. Because one, we need to screen more babies. Only when we screen more babies, we'll detect more babies with problems and then we will be able to manage them. The public healthcare program needs to be wholesome, expanded across the board. Most of the other public programs, definitely it will be only extended onto the public setups. But if there is a regulation which is present, then definitely even the private healthcare facilities will not shy away from doing it. And as a private healthcare facility, you do not need to wait for a government to tell you what to do. If you think it is important, definitely you can just start doing it straight away into your own setups. And the OBGYN and the neonatal societies come together and advocate these programs. And definitely it's being done, not that it's not being done. There are a lot of guidelines which have come from NNF, IAP, stressing the importance of newborn screening. There are articles you can see on FOGSI on the importance of newborn screening. ISPAT is actively working on the segment of newborn screening. So as an association, we are taking our responsibility forward and talking about what newborn screening is and how it should be done. So when we talk about newborn screening, there is a ambit of different kind of disorders that you can check for. And what we recommend is that right now we should be doing is basic universal screening, which is very important. So when we talk about basic, what should it include? It should include thyroid, 17-OHP, G6PD, hemoglobinopathies, and congenital hearing deafness. These are the 5 things that should be there of any basic universal hearing newborn screening program. Definitely, if the situation is such where you can offer more and there is no restriction on the cost, you can go on adding more. But this is something minimum and basic that should be offered across the board. Now, when you talk about newborn screening, the most important part is that it is once in a lifetime test. It's not that you will do it again and again. It's not a CBT test that you will be doing every 3 months, 6 months, or a year. It is just done once in a lifetime. So it's very important to be sure that the quality of report that we get is reliable, and we don't need to be suspecting that maybe this is anything less than what the report says. Now, if you talk about quality, I would very strongly recommend, it's very important which is the partner that you choose. So this is a small checklist. Maybe you can take a photo or a screenshot. This is something that you should think whenever you are choosing a lab. So to just briefly talk about the points which I would do when I choose a lab is whether the lab which I'm choosing is a very general or a general diagnostic lab, or are they focused into exclusively newborn screening? What is the kind of experience they have in newborn screening? Whether they are accredited with NABL, CAP, whether they are participants of the NSQOP for external quality assurance, whether their proficiency results, what is the kind of proficiency results that they are getting, how accurate the tests are, how accurate their results are, what is the type of filter paper they use, is it as per the CLSI guidelines or not, the Lancets, are they as per the CLSI or the WHO guidelines, are the filter papers bar-coded, and whether doing automatic sampling. This all helps in reducing errors. Whether do you have a backup instrument, because if some instrument fails, will they delay the reports? How frequently do they calibrate the equipment? So the calibration curves are available with all the labs. Which kind of technology they use, backend, fluorescent or photometry, because photometry is less sensitive than fluorescent. What happens when the screen test is positive? What is the internal protocol and what is the external protocol? How do they offer a repeat testing or not? What is the kind of post-test counseling support that is available from them? Do they store the sample in the future for some other genetic test or any other test if required in the future? How soon the reports are available? And what kind of experts do they have? So I think it is more important to look at the quality of the report rather than just the cost factor. But yes, I'm sure everybody can choose what is more appropriate in their setup. So I have a few cases to just highlight the importance of newborn screening. And we'll take one by one. If time permits, we'll go through all of them. Otherwise, we will stop short of as soon as Aditi tells us to stop. So I'll give you a point of view of the gynecologist. So let us look at this case. These are all, by the way, these are all actual factual cases. Only the names have been changed to protect the identity. So Mrs. Aarti, she is the primary gravida, was admitted in a private nursing home in a suburban Mumbai for delivery. She had a history of PIH, diabetes, anemia, and hypothyroidism on treatment, and she was well controlled on everything. With HB8, she was admitted on 4th of November 2021. Her random blood sugar was 73, TSH was 5.7, but on treatment, and LDH was 117. So basically, except for a little high TSH and low hemoglobin, everything else was okay. She delivered a healthy boy by elective LSCS on 2nd of November. Parental iron therapy was given on 4th of November. The mother and baby both were discharged on 5th November. So if you really look at this case, you think that the obstetrician has practically done everything right, and the hospital is doing a pretty good job, because they've probably done everything which is right. So this must be a lucky child. Okay. So let me explain why. So the parents contacted us on 9th of November and said that we have been told to get a newborn screening test done. So we got a newborn screening test collected on 10th of November, and the sample was received from the lab on 11th. The reports were issued on 12th, and the TSH was showing 34.59. Now the normal which is equivalent to. So if you have to compare it to the serum TSH, it is almost twice. So that is around 70 when you do it on blood TSH levels. So 34 is pretty high. The cutoff is 20. So it is about 20. So that is 34. So briefly talking about what congenital hypothyroidism is and what are the causes. Almost 85% of congenital hypothyroidism is caused because of thyroid dysgenesis. So basically, the thyroid gland itself is not formed. That is the most common cause of thyroid dysgenesis. Then there is hormonogenesis, which accounts for another 10 to 15%. And the rare things are TSH resistance, which is hereditary in nature, which is genetic in nature, and central hypothyroidism, which is also very rare. So the bulk of the causes is dysgenesis or hormonal dysgenesis. And since they are not genetically related to the parents, it's not necessary that there has to be a history. This can happen even without a history. And that's the importance of doing a newborn screening test, because you will never elicit any history in whether to decide to do it on a baby or not. So if you just look at this TSH graph, you see that after birth, it just takes 1 day for the TSH line. See, this is the TSH, for the TSH curve to settle and reach below the cutoff, which is 20. Okay, and that is why this test can be done anytime after 24 hours. So the earlier idea of saying that we should do a TSH only after 7 days doesn't apply in today's with the amount of data which is available today, because the cutoff is 20, and by day 1 this cutoff definitely goes down. So on by
Sorry to
30,
interrupt, sir. It's
Yeah.
only 2 minutes left.
Okay, fine. So on 13th of November, again the TSH was repeated, which was showing that it is 92. It was done the T3, T4 TSH, and TSH is 92. Definitely, this is a case of congenital hypothyroidism. Baby was started on levothyroxine, and then sonography was done, and it confirmed that it is thyroid agenesis. Hearing screen was done. The left hearing is failed. Okay, because this is all part of newborn screening. And then once the treatment started, the TSH has come back to normal. Now, a very small incidence or a small information just for you, there is a high prevalence of hearing impairment when there is primary congenital hypothyroidism. So that should be kept in mind. Yeah. So this is how the baby progressed. So quickly, we don't have a lot of time, and I will just go to another case. So again, similarly, non-suspecting case, public hospital, because we were doing a routine screening program here, the screening test was done, and the hemoglobin pattern was reported as F. F only means that this child doesn't have an A. A is not there, means this is possibly case of beta thalassemia major. So even the beta thalassemia major can be detected at birth, okay, if the percentage is pretty less. And this is confirmed by doing the test of both the parents, and both the parents have shown that there is a variant in their hemoglobin variants. Thalassemia beta traits are there, and that is why the baby's genetic mutation is also confirmed having beta thalassemia minor. So basically, even when we do a test at birth, we can detect beta thalassemia major. Okay. Similarly, a very simple case, another public hospital. Again, we were doing the newborn screening program there, and the G6PD result came out to be positive. No history of the patient, nothing. No family history. There is no jaundice, nothing. And G6PD was deficient. And it is again confirmed with the G6PD quantitative. And once it has been confirmed, only then we label these patients as having G6PD deficiency. And why I say in NBS is must is because as obstetricians, we definitely do so much of other things. Like we screen for Down syndrome, incidence is 1 in 800. Syphilis, VDRL, we doing 1 in 1000. Beta thal, we do for the mother and the father. It's almost incidence 1 in 10. On the other side, the MCGM panel, which we were doing, the incidence is 1 in 50. So you just look at this incidence and you will realize that definitely newborn screening is very, very important. And it fits into this screening guidelines and the criteria. So laying again importance of why data is important, and this is what we should be doing for everybody. So to end the slide, to protect the baby and not allow them to fall into the valley of morbidity and mortality, the obstetrician and pediatrician have to work in hand. If you just believe that the pediatrician will be able to manage and convince the parents on doing newborn screening, I think we are grossly mistaken. The newborn screening talk has to start somewhere in the 3rd trimester by an obstetrician telling the parents that after your baby is born, we need to do a newborn screening test, and we will talk about it more when the baby is born, and the pediatrician also talk about it, and then the pediatrician takes the talk does the test in the hospital itself before the baby is discharged. And that is the only way we can save the babies. So, thank you very much.
That was a very interesting talk, Dr. Saurabh Dani, on universal newborn screening. And rightly touched upon, since obstetricians have been spending so much of time with the pregnant lady, they have got a faith on them, and they would be the right persons to, initiate this talk on newborn screening. That's some really good work that you have done through the MCGM, the municipal commission, and the municipality. So we quickly move to the next speaker, Dr. Sudha Tandon. It is my privilege to introduce her to you. She is gynec endoscopic surgeon and an IVF consultant, having an experience of more than 25 years. Dr. Sudha Tandon has her fertility, IVF, gynec endoscopy, and maternity hospitals with branches at Chembur and Navi, Mumbai. I love her tagline, inspired by purpose, driven by passion. Dr. Sudha Tandon was the Joint Secretary IAGE in 23-24, that's a present term, MOGS and ISAR committee member.
Madam, you can go ahead.
Okay. Yeah, very reputed, well known, and favorite, So, the topic for today is hysteroscopy for benign disorders. Over to you, madam.
All right. So I'll share my screen. Just give me a minute. It's very good topics. I like the topic of Dr. Saurabh Dani, though I just heard for a short time. Yeah. So share. Is it visible? Hello?
Yes, ma'am.
Is my slide visible?
Yes, ma'am, it's visible.
Sorry?
Yes,
No.
ma'am, it is visible.
Only your
Not
introductory slide. No.
Yeah, ma'am, you can move your slides.
visible?
Yeah.
Okay. It's visible, right?
Yes, ma'am.
Yes, yes, now it's visible.
All right. So the topic for today, since this focus is on AUB, is hysteroscopy and AUB. We'll just have few slides on AUB to begin with, and then we'll go to the videos. This is the most common complaint for which the patients come to us. Almost 70% of our consults are because of AUB, and 1/3 of the women at some stage of their life will have AUB. So we need to know the cause and do the proper therapy. This also, we are extremely familiar with the palm coin classification. And because we're talking about hysteroscopy, I'm just going to focus on the polyp adenomyosis, leiomyoma, malignancy, and hyperplasia, which are the structural causes of AUB. So this is what it is. So we score it whether it is present or absent. And yeah, so about polyp, 8 to 35% of the would have it. We can diagnose on sonography, on saline sonography, hysteroscopy. The classify in the dimensions, location, and the number. The premenopausal women, it's 64 to 88%. And not forget, it's a very important cause of postmenopausal bleeding, and it will definitely get missed if only a DNC is done. And to remove the polyp properly is extremely important in these postmenopausal women, and there could be associated other polyps too. So this is how the polyp. Saline sonography and on hysteroscopy. Adenomyosis is where there is ectopic endometrial glands and stroma within the myometrium, and there is hypertrophy and hyperplasia of surrounding myometrium. And this is the usual presentation: painful periods, heavy periods, uterine enlargement. and not
Hello, Dr. Sudha ma'am. Hello. Hello, Dr. Sudha ma'am. Can you hear me?
Mic is.
Hello. Dr. Sudha ma'am, you can continue switching off your video since your network connectivity is little bad. Ma'am, you're on mute. Dr. Sudha ma'am, you're on mute. Hello ma'am, can you hear us?
I can hear you. Can you hear me?
Yes ma'am, now I can. Ma'am, can you switch off your video and start with your presentation? It will be better then. Hello.
No.
Hello ma'am.
Yes.
Can you start sharing a presentation and just switch off your video since your connectivity is bad, the network connectivity.
These are all videos only.
Ma'am, we can skip the videos of your presentation. Also, can you just switch off your camera because then your network might work properly.
So is it better now?
Yes, ma'am. Now you can start your screen sharing.
Yeah, I'll do it again.
Yeah.
Because I've switched on, I have... Can you see my screen?
Yes, ma'am. It's visible.
Yeah?
Yes, ma'am. It is visible.
All
you
right.
can continue.
Yeah, okay. Yeah. So then coming to the first thing is about the submucous myoma. We all know this, the FIGO classification. So it could be 0, 1, and 2 for which the hysteroscopy is done. And if it's pedunculated, it is simple. But if it is stage 1, where more than 50% is into the cavity, that's also okay. But the stage 2 ones, I think one has to be very careful. In the stage 2 fibroids, where more than 50% is in the intramural, one has to take this seriously, especially with fluid overload, and not do it as your initial procedures. So we'll just skip this. Yeah, but it's important also to look into the step, this classification by LASMER, and look at the size whether it is between 2 and 5 centimeters. Look at where it is, where is the base of the fibroid, the penetration, and the lateral wall. And so you have low complex fibroids, is 0 to 4, 5 to 6 is high complexity hysteroscopic myomectomy. We could give her GnRH agon and consider 2-step procedure. And 7 to 9 is consider alternatives. Like suppose you have a big fibroid where more of it is into the myometrium, consider doing a laparoscopic procedure. So this is the way we all know that we diagnose, and it's also important to distinguish from adenomyoma. Hence, a very good transvaginal sonography mapping of the myoma is very essential, especially if you have somebody to do a 3D sonography, it becomes very essential. And do an MRI. In few cases, few indicated cases, because there could be multiple fibroids, and you must know where the fibroids are if you're doing a myomectomy. And also look into the penetration in type 2 to type 5 to decide the course of your surgery. So this is the GnRH agon. How does it benefit? Causes amenorrhea. You can have a hemoglobin comes to normal. It causes thinning of the endometrium and decreases the size of the fibroid and reduces the surgical time and fluid absorption. You could also give misoprost, intravaginal divided opinion, intracervical vasopressin can be given a dilute vasopressin at 3 and 9 o'clock position. That also reduces the fluid absorption and the blood loss during for the myomectomy. So these are the other ways. I will straight away go to the videos, but these are other ways of which you can do a myomectomy. What I have been doing is by resectoscopy method, and it's a continuous flow design. There's a constant turnover of distending media that facilitates visualization by rinsing out the blood and the debris. You use a monopolar cutting current. With monopolar, use a non-conductive distending media. Like 1.5% glycine. With bipolar resectoscope, use a conductive media like normal saline, and continuous low voltage current is used to cut strips, and then you from the top to the bottom, and you take out these pieces by using an ovum forceps. Okay, so morcellation is also one very good technique and good equipment, which is energy based. It's a mechanical energy, so you're not using energy. You're not using current, basically. Does not use electric current. And but for small fibroids, it is good enough. And the cost is also a factor which needs to be considered. And you have 2 types of morcellators. You can also think of doing a cold loop hysteroscopic intracapsular myomectomy, where you do the cold loop, the meson loop is inserted in the cleavage plane, and fibroconnective bridges anchoring the myoma to the pseudocapsule, and hence the intracavitary component becomes the fibroid, the intramuscular fibroid becomes an intracavitary one. And these are the complications which one must remember. And trust me, it can happen anytime. And the complications of fluid overload is extremely scary and extremely serious, and it can be really very fatal. So one really needs to be very careful of this. And it's a very dangerous complication. Severe can cause pulmonary edema, cerebral edema, and even death. And 750 for planned termination. And if it is more than 1,000, you have to stop the procedure. And you may intrauterine adhesions and infertility. Intrauterine adhesions because of submucous myoma are very common, and you really need to you can do a second look hysteroscopy and take care of these adhesions, and also use some adhesion barrier methods. So normal saline with bipolar is less risk. By that, it doesn't mean that with bipolar with normal saline, you can use as much fluid. It is equally important to keep your inflow, outflow, even when you're using normal saline, but it's relatively more safer than using glycine. So, and you must measure the fluid which is getting absorbed. So these are the complications.
Sorry to interrupt, ma'am. Ma'am, you have 4 minutes more.
Okay, so we'll just look into this video. Yeah. So type 2 submucous fibroid. on the left anterior wall. It's important that when you're doing the hysteroscopy, before you start, your position where the fibroid is and how, as compared to your two ostia is the limit that one should know. So internal os and ostia is where you should remain into that field and keep taking strips. So you know which is the anterior wall, which is the posterior wall, and you keep taking strips of the myoma. And once you have lots of strips which are collected, you take an ohm forceps. And it's important that at the end of the procedure, you check for hemostasis and also that the entire fibroid has been removed from the base. Now, this is another interesting case where you see when you put your telescope with the resectoscope inside, you really cannot know where it is. So again, as I said, you must look, so I'm riding above the fibroid. Yeah, so it looked as though, now see this, it is from the anterior wall. That is what I meant, that you look at the two ostia, so it is above it. So of course, holding the camera and holding the entire assembly is very important for you to know. Otherwise, the procedure remains the same. So this is about polyps. I think we'll skip the theory part of it and we'll go straight away to the video. So this is the endometrial polyp. Again, when you start, you have to go and see from where it is arising. So looking at the tubal ostia, okay, look at the vessels which are seen and the base. Okay, so again, it's extremely important to hold your assembly properly, resect it, so it's arising from the right lateral wall. And these are little difficult cases because your entire assembly, the way you are going to hold your, how you're going to resect the angle becomes a little tricky. Now, this is again another polyp which is seen at the external os. Now, even if it's seen at the external os on a speculum examination, it is a good idea to do a hysteroscopy, because if there are any polyps beyond that, or also that you remove the polyp right from its base, only then the patient will become completely all right. So this is again seen at the external os. Now, this is multiple polyps. Now, this is where there is infection, chronic endometritis, and you can, for these small polyps, you can, no need of doing a resectoscope, you can cut it with the scissors around it and then take a grasper and take it out from the hysteroscopic grasper. These are 5 French instruments which can be passed from the operating channel, and you do it. Now, this is, now this is how which is malignant. Now look at the bizarre appearance of the submucous myoma. A young patient, 42-year-old, diagnosed preoperatively as submucous fibroid. And even I didn't think it was malignant to begin with. But when we resected out completely, when it was sent for histopathology, it came out as malignant. So one needs to be very watchful, because these were two multi-lobed and not a normal looking myoma. This is what I would say at this time. Now, endometrial hyperplasia, especially if it's associated with atypia, one needs to be follow up these patients. Okay, yeah. So very hyperemic growth. This is, of course, hyperplasia, where you have the cheesy-like tissue edematous. This is a fibroid. So I thank you. I thought showing the videos is important. Yeah, I'll stop my share.
Thank you very much.
Very nice, very nice. Madam, I have a question for you.
Yeah, please.
Madam, what is your experience with hysteroscopic morcellator?
I have no experience. I don't possess.
Okay.
But whomever
looks
has,
like a magical instrument.
yeah, it is. Especially it is very good for polyps and small size submucous fibroid. And if you want office hysteroscopy,
Okay.
Yeah, this is what
But for
I
the used ones, the resectoscope is the gold standard, is what you feel.
resectoscope is the gold standard, but the thing is the training in resectoscope, that is what is everybody's not comfortable, and
Absolutely.
it is on the way out, but I think it will remain for good, because
Definitely,
yeah,
definitely.
there's no substitute for it. I
Yeah,
don't
we don't have a better option. We have to just quickly
Yes.
go in and quickly come out. That is the
Yes.
principle.
Yes, so I think it does have a place, but the cost also, they are now coming down. But again, for an individual private practitioner, how many cases you would have,
Absolutely. Unless you are doing a lot of
to justify the cost, if you have all the money and if it's okay, you can buy, it's fine.
Okay. Thank you so much. Thank you.
Thank you. Yeah.
Yeah.
I would log out because I have a flight to catch for the Nagpur conference.
Thank
So,
you very much, Dr. Sudha Tandon,
Thank
madam.
you.
You've really
Thank you.
explained it, simplified it for all of us. Very, very clearly explained.
I hope I have done justice to the topic, because just 15 minutes to show videos and
Lovely videos, but we enjoyed them.
And very clearly explained. Thank you
Yeah,
so much.
absolutely.
Thank you again for the opportunity, and best of luck to everyone. Thank you.
Thank you.
Which brings us to the next talk, the next speaker. We have Dr. Aditi Dani, who she is a chief fertility consultant at Ria Fertility and IVF Center, Grant Road. Besides that, she is also affiliated with Breach Candy Hospital, Saifi Hospital, Elizabeth, SRCC, and Ruxmani and Jain Hospitals. Dr. Aditi has completed her post-graduation from KEM Hospital, after which she was invited for a fellowship in reproductive medicine at Hanover, Germany. She has over 15 years experience in treating infertility patients, and she's an ex-youth council member of the Mumbai OB-GYN Society. She has done a lot of social awareness work, which includes working with the Geo Parsi in providing fertility treatments to Parsi couples. And through that, they have delivered 33 Parsi babies in the last 5 years. She's been instrumental in providing health awareness to adolescent girls in schools and in corporate employees. And these programs have been much appreciated. This is something which is really the need of the hour. And Dr. Aditi has also been actively writing articles for fertility awareness. She's been featured in ABP Maja, Red FM, numerous other interviews for the same topic. Today, she will be talking to us on the new guidelines in endometriosis. So, welcome, Dr. Aditi. All yours, Dr. Aditi Dani, please.
So, can you hear me?
Yes, we can.
Yeah, so I think I'll have to first apologize because I have a really bad cold, but I'll still try to stick to this presentation and make it as clear as possible. I'll hopefully get a little better as I present. So I think, like my voice, I've been given a very difficult topic to discuss today, which is new guidelines on endometriosis. Now, having been through the guidelines and the current literature on endometriosis, I have finally decided that today I am going to actually focus on one guideline which is very comprehensive, and it is about 192 pages long, which is the ASHRAE guideline on endometriosis that was published in 2022. So to start with, I think we all know that we define endometriosis as a disease characterized by the presence of endometrium, like epithelium, and or stroma outside the endometrium and myometrium, usually with an associated inflammatory process. Now, this particular guideline deals with a lot of subunits coming from diagnosis, moving to treatment, to recurrent endometriosis, to endometriosis in adolescents and in postmenopausal women, to extrapelvic endometriosis, asymptomatic endometriosis, along with the prevention of endometriosis and its association with cancer. Having said that, I think we all know what are the classical symptoms that we do associate with endometriosis. I don't think I need to really detail these. Start with the basic guideline. Now, with regarding the diagnostic test, what does the PHA guideline state? It states that the clinical examination, including a vaginal examination where appropriate, to identify deep-seated nodules in endometriomas is actually one test which does not have a very good diagnostic accuracy. So in women where we suspect endometriosis, further tests including imaging should be considered. Now, do not use measurement of biomarkers because we end up using CA125 so much to diagnose endometriosis. But the guidelines says that the biomarkers are not really dependable, whether in the endometrial tissue, blood, menstrual, or uterine fluids. Use imaging as an ultrasound or an MRI in the diagnostic workup for endometriosis. In patients with negative imaging results, but where empirical treatment was unsuccessful or inappropriate, please consider laparoscopy for diagnosis and treatment. Laparoscopic identification of endometriotic lesions is confirmed by histology, but negative histology will not entirely rule out the disease. Having said that, we'll move on to the treatment of endometriosis. The first thing is endometriosis-associated pain. And I think we all know that this is one nagging pain that even we find difficult to treat in patients. The very first line treatment for this ends up being analgesics.
Ma'am.
Sorry?
Ma'am, do you have any slides to share? Are you sharing any slides?
1 minute. Is this better?
Ma'am, are you sharing any slide?
No, is this better?
No, we are not able
Ma'am,
to
your
see any
voice is
slides.
better.
Your voice is good. We can see.
Slide?
I am sharing my slideshow.
It's not visible. You have not started sharing.
You can't see my slides?
No, ma'am.
You will have to stop sharing and share again.
I'm trying to share my screen, but it doesn't seem to work. Is there any way that you can do it? Or 1 minute?
Ma'am, what's the issue? Ma'am, you can take the share screen button and start.
I am trying to press on the button, yeah? You still can't see my screen?
No, ma'am. Can you just share it with me? I'll share your PPT if it's possible for you to share with me.
How do you want me to share the PPT to you?
By WhatsApp or email?
Just 1 minute.
Yeah, it started. It started.
Can you get
now it started.
Now just
ma'am.
make it full screen.
1 minute. I'll just start the... Is this better?
Yes, ma'am. Better. Thank you.
Perfect.
Perfect.
Sorry. So analgesics, the first line of treatment that we provide. In case these do not work, we move on to hormonal treatment. And obviously, as all of us know, we can start with combined oral contraceptive pills, progestogens, GnRH agonists or antagonists as one of the options to reduce pain. Now, consider individual preferences, consider the efficacy, side effect, costs when we actually try to select one of these in treating endometriosis-related pain. When it comes to combined hormonal contraceptives, any form, whether it is oral, it's a vaginal ring or transdermal, have the same effect. When it comes to progestogens, obviously, I think the most common that we've been using is Dynogest, but then you can use the progestogen of your choice. Even a subdermal implant will do, or an IUCD will also do that contains progesterone. GnRH agonists, yes, they are mostly prescribed as second line because of the side effect profile. It's just better to combine an add-back therapy when you're giving a GnRH agonist to treat endometriosis-related pain. Women with endometriosis-related pain refractory to other medical or surgical treatment, it may be recommended to prescribe aromatase inhibitors as they reduce the pain. They may also be prescribed in combination with oral contraceptives, progestogens, agonists, or GnRH antagonists. Surgical treatment is one of the options to reduce endometriosis-associated pain. But when surgery is performed, obviously consider excision over ablation for removing endometriosis. Luna, PSN, these are supposedly outdated procedures and are not really recommended currently as surgeries of choice. When performing surgery for endometriomas, cystectomy or a CO2 laser vaporization are the methods of choice, and aspiration, drainage, and coagulation do not really come into the treatment pro forma of ASHRAE because they actually increase recurrence of the endometrioma. Now, when you're doing an endometrioma surgery, please exercise specific caution to minimize ovarian damage. Consider hysterectomy with or without removal of the ovaries, with removal of all visible endometriotic lesions in patients who do not wish to conceive further. When a decision is made to remove the ovaries, the long-term consequences of early menopause and possible need of HRT should be considered. A total hysterectomy is preferred. There are currently no prognostic markers that can be used to select patients that would benefit from surgery. Adjunct medical therapy is not recommended to prescribe preoperative hormone treatment to patients who have to undergo surgery, but it may be given post-operatively to improve the immediate outcome of surgery for pain if they are not desiring immediate pregnancy. Having said this, all the alternative therapies, non-medical, Chinese medicine, nutrition, electrotherapy, acupuncture, physiotherapy, exercise, or psychological interventions, ASHRAE takes its hand back. The ball is in your court. You choose whether you want to give those to your patients or you do not, but the benefits and the harms are unclear. When it comes to infertility, do not prescribe ovarian suppression, whether it is pre-surgery or post-surgery for women who want childbearing. So that is the primary, I think, message from all this particular guideline when it comes to treatment of infertility. Now, in those infertile women with endometriosis should not receive pentoxifylline or other anti-inflammatory drugs or letrozole outside ovulation induction to improve natural pregnancy rates. Operative laparoscopy could be offered as a treatment option for patients with stage 1 to 2 endometriosis as it improves the rate of ongoing pregnancy rate. Having done this, IUI can be considered as a treatment option immediately in patients with stage 1 and 2 endometriosis. Although the value of IUI in infertile women with stage 3 and 4 endometriosis with tubal patency is uncertain, the use of IUI with ovarian stimulation could be considered. ART can be performed in infertility-associated endometriosis, especially if tubal factor is compromised, or there's a male factor associated, or in case of low EFI, or if other treatments have failed. A specific protocol for ART is not recommended. Women with endometriosis can be reassured regarding the safety of ART because the recurrence rates are not increased. In women with endometrioma, clinicians may be advised to use antibiotic prophylaxis to reduce the risk of ovarian abscess formation. Extended administration of GnRH agonists prior to ART treatment to improve live birth is not recommended. There is also insufficient evidence to recommend prolonged administration of combined oral contraceptive pills or progesterones as pre-treatment to ART. Clinicians are not recommended to routinely perform surgery prior to ART. No recommendation to routinely perform surgery for ovarian endometrioma prior to ART. However, it may only be considered to reduce pain or make the follicles more accessible. The decision to offer surgical excision of these endometriosis lesions prior to ART should be guided mainly by pain symptoms and patient preference, as its effectiveness and reproductive outcomes are uncertain. Thus, in case of extensive ovarian endometriosis, it is just best to discuss the pros and cons of fertility preservation in women with endometriosis. The true benefit, though, of this procedure remains unknown. Backed on pregnancy, They should not be advised to become pregnant. There are a lot of times we tell our patients that, oh, you have endometriosis, pregnancy is actually going to sort your issue. This may really not happen because pregnancy does not always lead to improvement of symptoms or reduction of disease progression. Complications related directly to pre-existing endometriotic lesions are rare, but the patients need to be counseled as such. And these are related to decidualization, adhesion formation or stretching, and endometriosis-related chronic inflammation. There's also an increased risk of first trimester miscarriage and an ectopic pregnancy. Recurrence of endometriosis. Prevent recurrence. When surgery is indicated in a woman with endometrioma, like we've already discussed, clinicians should perform cystectomy rather than just simple aspiration. Consider an LNG-IUS in a patient to relieve pain and reduce recurrence. After surgical management of ovarian endometrioma in patients who do not want to get pregnant immediately or for long-term hormone treatment, for prevention of recurrence of deep endometriosis and associated symptoms, long-term administration of post-operative hormone treatment can be considered. And ART per se is not shown to increase the recurrence rate. Treatment of recurrent endometriosis lies in a repeat surgery or hormonal treatment. The choice lies with the clinician and the patient. In adolescents with endometriosis, the issue becomes a challenge. They're growing. Surgery is really not going to be a primary option. A careful history to confirm if the patient has endometriosis is so essential. The same symptoms that we use in adults would be used with adolescents. In the absence of evidence for adolescents specifically, the recommendations for clinical examination in adults can be applied. Transvaginal ultrasound is recommended if it is appropriate. If transvaginal ultrasound cannot be done, then a MRI, transabdominal, transperineal, or transrectal scan may be considered. Serum biomarkers, like we have said, are not recommended for diagnosis. Now, in adolescents with suspected endometriosis, where imaging is negative, medical treatments have not been successful, then a diagnostic laparoscopy may be considered. Also, if a laparoscopy is performed, clinicians should consider taking biopsies to confirm the diagnostic histology, but then a negative histology does not entirely rule out the disease too. In adolescents where an endometriosis is confirmed, again, an LNG-IUS, if possible and appropriate, may be used, or hormonal contraceptives may be used as first line of therapy. NSAIDs for treatment of pain can also be used as an add-up therapy. On those patients who have been confirmed on laparoscopy, again, hormonal contraceptive or progesterone therapy, wherein these have failed, consider prescribing GnRH agonist final option for up to a year. But these have to be combined with an add-back therapy. Also consider surgical removal of endometriotic lesions to manage endometriosis-related symptoms. But please explain to the adolescent that a recurrence rate for endometriosis is very high. Fertility preservation should certainly be discussed with these young girls. Endometriosis and menopause. So when a woman attains menopause, I think the patient as well as the clinician a lot of times give a sigh of relief that, okay, fine, we've cured something now, hopefully, that is incurable. But unfortunately, endometriosis is known to give symptoms even after menopause. So for those women who actually have their symptoms, consider surgical treatment. For those who actually present with signs of endometriosis or pain, there's an uncertainty towards the risk of malignancy in postmenopausal women. But if a pelvic mass is detected in these women, the workup and treatment should be performed according to the existing national oncology guidelines. For postmenopausal women with endometriosis-associated pain, an aromatase inhibitor would be an option if surgery is not feasible. If there are menopausal symptoms in a patient known to have endometriosis, well, menopausal hormone replacement therapy may be administered. Avoid prescribing estrogen-only regimens for the treatment of vasomotor symptoms, though, as these may be considered associated with a high risk of malignant transformation. Continue to treat women with a history of endometriosis after surgical menopause with combined OC pills at least up to the age of natural menopause.
Sorry to interrupt, ma'am. Last 3 minutes.
I think I'm done. I don't think there's a lot left anyways. So health concerns with endometriosis. Women with endometriosis who have undergone a bilateral salpingo-oophorectomy as part of the treatment have an increased risk of diminished bone density, dementia, and cardiovascular disease. It also behooves us to know that these women who have endometriosis have an increased risk of cardiovascular disease, irrespective of whether they've had an early surgical menopause. Extrapelvic endometriosis is treated according to the site of the endometriosis, obviously. Asymptomatic endometriosis. This is very interesting. Clinicians should not routinely perform surgical excision or ablation for an incidental finding of asymptomatic endometriosis. Should not prescribe medical treatment in women with incidental finding of endometriosis, and routine ultrasound monitoring may be considered. Primary prevention of endometriosis, usefulness of hormonal contraception is uncertain. Genetic testing is only in a research setting. Cancer, women have to be informed of the risk of developing cancer that is not associated, it's not a higher risk of developing cancer in women with endometriosis, though they are at a higher risk of ovarian, breast, and thyroid cancer in particular. Cancer prevention measures have to be explained, and cancer screening is as per protocol of the particular country. Now, there is epidemiological data mostly on ovarian endometriosis showing that complete excision of visible endometriosis may reduce the risk of ovarian cancer. The potential benefits should be weighed against the risk of surgery. Now, finally, I think this is the last slide. Let me highlight the changes that this particular ISHRI guideline has done compared to the previous guideline. When it comes to diagnosis, this particular guideline says that laparoscopy is no longer the diagnostic gold standard. For treatment of pain, GnRH antagonist is second-line treatment option. Post-operative medical treatment may be offered to women not desiring immediate pregnancy. For treatment of infertility, extended administration of GnRH agonist prior to ART is no longer recommended. Endometriosis fertility index added to support decision-making. Danazol, antiprogestins, Luna, PSN, and anti-adhesion agents are no longer included in these recommendations. Thank you.
Thank you very much, Dr. Aditi Dani. Very clearly, crisply, concisely, you have covered the topic. We have been getting a few questions even for the previous speakers. We'll take them all at the end. The last talk for this evening, welcome Dr. Atul Ganatra. Dr. Atul Ganatra is a consulting obstetrician, gynecologist, and endoscopic at Fortis, HMN, and Jupiter Hospitals. VP of IMA Mulund. He is also the managing committee member of MOGS, the director of Ganatra Hospital and director of Progeny IVF Center, joint secretary of IAGE for 2021, and VP of FOGSI for 2021. Welcome, Dr. Atul. Today he will be speaking on the medical management of AUB. All yours, sir. I think your connection is unstable.
Atul, we can't hear you. Atul Ganatra.
Sir, you can try switching off your video and start sharing. Sir has disconnected.
I think Manjeet, till he connects back, we can start asking questions.
Okay. So let me just read what is there. There's a question from Dr. Anita who asks that ANC panel tests, please tell what all are must. I think Dr. Saurabh Dani, this is for you.
ANC panel, I didn't talk about that today.
You spoke about the MBS. So, yeah, I mean, that's the closest. The others are all endoscopy and AUB.
Just say the question again. She wants to know what is the ANC panel.
Yeah, what is the must types? I don't know if she meant MBS, but it's written ANC.
Okay.
Yeah.
So, anyway, FOGSI has a guideline which is called prenatal investigations. So if you just go to the FOGSI website, then we will be able to get those guidelines which talk about which are the important antenatal tests that should be done. Moving to the question, if it is about FBS, then as I just shared in the PPT, maybe yeah, hi. Atul, you are back?
Yes, yes.
Yes. Okay, fine.
Can I just share my screen now?
Yeah,
Yes,
little later.
please.
Yeah, we'll start with Dr. Atul first.
You see my screen now?
Yeah, you could open the PowerPoint. We can see your entire screen.
Is it seen now?
No, not the PowerPoint.
Can you see my screen?
Atul, you have shared the desktop. So
Now?
you will need to select that PPT.
I have the PPT, but let me just check again.
So you can start again, sharing.
Oh my God. Okay. Now is it seen? You see my screen now?
No, we can.
Sir, I think your net is also unstable. Can you try switching off your video and continue? Also, you have to stop your share
Okay.
and start your sharing again. Then it might be visible, the PowerPoint.
Crazy. Okay. Let me just stop my video. Now is it seen? Hello?
Yeah.
Yes, sir. Yes. You can
You
start.
just to do full screen. Yeah.
Thank you, Saurabh. Sorry for the internet issues. I'm in another hospital as where I was operating.
Yeah.
Okay. So once you stop learning, you stop dying. I think this is where our CME Zoom COVID did preferred home place and do some learning. This is what I'm supposed to be talking on, medical management of abnormal uterine bleeding. This is a no-brainer. If I have a patient like this, there is no question of medical management. She's going to require surgery. This patient had more than 30 fibroids. But my problem comes when I have a patient with a normal size uterus. Now, look at how good procedures get a blame. This is a patient who was referred to us by saying that the Mirena is not working. If you can see here, this patient was reported to have submucous intramural fibroid that actually had submucous fibroid. I will show you the previous picture now. This is the Mirena that was inserted in her in the OPD. But unfortunately, she had a large submucous fibroid. Now, medical management is never going to work if a patient has a submucous fibroid like this. So I think what Aditi also pointed out, we have to be rational with our investigations. What the mind doesn't know, the eyes don't see. Ultrasound has to be preferably done by the gynecologist. And then you will not make mistakes. Absolutely normal size uterus, and she was advised a hysterectomy. We put in an LNG intrauterine device. Now, about 15 years down the line, she had 3 LNG IOS insertions from us. So one has to be really rational as to what is the problem with the patient. Menorrhagia, the older definition, when the patient says so, excessive menstrual blood loss, which interferes with a woman's physical, emotional, social quality of life. This is normal or usual. They will say usual bleeding. Once referred to a gynecologist, between 60, 40, and 20% of them will have a hysterectomy. 80,000 to 1 lakh hysterectomies are performed every year in America. I don't think we have a count here. And 5% of women between the age of 30 and 49 consult their GP, and only about 58 to 47% to receive medical therapy prior to the time that they come to a gynecologist. And this amounts to about 12 to 15% of gynecological references. So what is the choice that we have? We have a choice between hysteroscopy, 50 to 80% satisfaction, 30% amenorrhea, hysteroscopy plus ablation, 95% satisfaction, and a hysterectomy, which obviously has about 100% amenorrhea rate and a 95% satisfaction rate. These are the various terminologies. And we know that Munro et al. In the FIGO guidelines completely changed. In 2009, the terminology is meant for heavy menstrual bleeding. And all these, when we were resident doctors, menorrhagia, hypermenorrhea, hypomenorrhea have been changed to certain simple terminologies like AUB, heavy menstrual bleeding, heavy and prolonged menstrual bleeding, intramenstrual bleeding, and bleeding. Then came up again, and that spoke about nomenclature of the FIGO, etiology, symptoms, clinical presentation, and diagnosis. They said the palm coin classification could have problems in AUB because of polyp, adenomyosis, leiomyoma, malignancy or hyperplasia, and coagulopathy or reduction, endometrial iatrogenic, not yet classified. And today, we will have to fit our patients into one of these categories. Fibroids, of course, they've been described from grade 1 or grade 0 to grade 7. And if you have a submucous fibroid of 0 or 1, no amount of medical therapy is going to work unless you knock that fibroid off. But fibroids between 3, 4, and 5, or 6 and 7 hardly ever cause heavy menstrual bleeding. Clinical presentation: soaks one or more pads or tampons every hour for several hours, has to change pads and tampons, needs double up of pads, menstrual period lasting for more than 7 days, and a menstrual flow with blood clots of more than 1 inch. And it is a clinical diagnosis. It will, I mean, if a patient tells me she has heavy menstrual bleeding, and if her hemoglobin is 14 grams, I know what kind of treatment she's going to need. So this is the flow chart that one needs to follow. Of course, proper history of the patient. Initial investigation, I would just refer to a TSH, CBC, or a sugar. An examination, a uterine evaluation, structured history, look at the ovulatory function. Find out from the patient how many days does she menstruate, how often does she get her period. I would just get a CBC. I don't think coagulopathy is something that is necessary. Duration of flow, measurement of hemoglobin, very, very important. Ultrasound, assessment of the endometrial cavity, and assessment of coagulopathies. I work in a tertiary hospital, and we get patients of all types, right from patients who had a transplant, patients who had a metal valve and are on anticoagulants like and have heavy menstrual bleeding, and many other hemophilics also come to us with bleeding. So you need to really rationalize your treatment, and very rarely we go into investigations like 1 Milibranch factor or more complicated ones. I think simple ones is what we need to assess very often. And the initial screening that you can see, CBC and platelet count, prothrombin time, and fibrinogen, which is barely necessary unless the hematologist wants. Again, it's very difficult. My young patient of AUB was around 7 years of age, and Aditi has spoken about it. I don't know how to counsel this patient. She was a hemoglobin of 4 grams, bleeding continuously for a month, not stopping, but you need to put these on hormones and, of course, improve their hemoglobin status. Of course, you need to look at the rarer causes like the 1 Milibranch factor. You'll be able to gauge as to what investigations you want to do. Routine investigations should be vaginal examination. Ultrasound is the first diagnostic tool. Hysteroscopy, ICOG guidelines says hysteroscopy is only a diagnostic tool and should be done if the ultrasound is abnormal. Saline infusion sonography, MRI, or investigation should be at the last resort. If I have a doubt whether I'm dealing with a submucous or an intramural, then I think the MRI will hold some importance. Of course, dilatation and curettage, as told earlier, it should be therapeutic. It should not be a diagnostic procedure. I think a hysteroscopy is very, very important. Medical management could be antifibrinolytics, NSAIDs, OC pills, oral progestogens, GnRH analogs, LNG, IUS. This is obviously my all-time favorite. And here, DNC, ablation, embolization, resection, and hysterectomy. Medical therapy is usually considered as the first-line treatment for heavy menstrual bleeding. However, where pharmacological treatment is ineffective or inappropriate, non-pharmacological treatment is more suitable. we need to know a little bit about the progesterone you're going to deal with. And that is why this chart is something should be on your WhatsApp. Which stage of progesterone you're going to use, whether you're going to use a medroxyprogesterone or you're going to use any other form of progesterone or a norethisterone, a norgestrel or a desogestrel or a drospirenone. And we're going to talk about each one of them after the other. The first generation, norgestrel and MPA. Norgestrel is a part of the overall G, which was an all-time favorite of our teachers. Overall G for 21 days in a month for the next 3 to 4 months. Then the second generation came in, overall L or dualaton, which had levonorgestrel. And then we have the Novolon, which is desogestrel. And now the most recent and the most acceptable one is drospirenone or drugs. So the estrogen is the same, we all know. It's either 15, 20, or 30 micrograms. It's the progesterone that keeps changing. And this is obviously the first rule. So there is an evolution of progesterone, right? 17-hydroxyprogesterone to spironolactone. And these are the other progesterone that we will, in short, talk about. My first target for my patient is if I can't do her any good, I must not do any harm. So please be very rational with your treatment. There were serious threats about the pill which came in, about venous thrombosis, stroke, and myocardial infarction. And that's why the pill completely was stopped. But I think it's something that we write very often, and my boss used to say, all medicines are safe, some women are dangerous. Non-RCTs, combined oral pills, OC pills, if you have a heavy menstrual bleeding patient 3 times a daily for a week, or MPA 3 times a daily for a week. This is an old ICOG guideline. Bleeding stops in about 88% of patients who took OC pills and 76% who took MPA. So if the patient has heavy bleeding, a single tablet is not going to work. You obviously need to look at the medical eligibility criteria, which was by the CDC and the UFDA. And if they say 1, 2, 3, 4, now you have the proper WHO wheel for medical eligibility criteria. As to if a patient has any medical disorder, what kind of therapy you're going to give the patient. And so for all patients, there are contraindications to these therapies to consider. I still remember I gave an OC pill to a patient who, and if you see the brochure of the OC pill, it has about 2,000 words, and a patient went home and called me and says, "Doctor, I'm an epileptic, and this brochure says that we should not give OC pills to an epileptic." So I think we need to read the brochures very well before you write it. All patients of ours who are prescribed hormones of any form get this stamp on our prescription pad that if you have any headache, giddiness, nausea, vomiting, or cramps in legs, report to us immediately. And this is something that we've been doing for more than 20 years. So now if you have a patient with heavy menstrual bleeding, the College Committee says that we must give conjugate 25 milligrams every 4 to 6 hours. Again, not available in our country. Or you could give combined OC pills, we said 3 times a day for 7 days and gradually bring it down. Or you can give medroxyprogesterone 20 milligrams a day, three times a daily for the first couple of days. Tranexamic acid is something that we use very, very often, 3 times a day for 5 to 8 days. Once you've taken care of the crisis, that is a heavy or a continuous bleeding crisis, you need to look at long-term therapy. And I tell my patients that it is the progesterone in your body that is creating the havoc. Whether it's an adolescent or a perimenopausal patient, is the progesterone that is dropping. And that's when you have to give them the choice between giving them either MP and norethisterone for the next 6 to 8 months, or giving them norethisterone 10 milligrams twice a day, or you could get an LNG inserted into the uterus after doing a hysteroscopy. And if a patient is receiving IV conjugated equine estrogen, add progestogen, or transition to OCs, you should not give unopposed estrogen to any patient for a very long time, just to tide over the crisis. So menorrhagia, desmopressin is something that was in vogue in between inherited bleeding disorders. General principles and use of desmopressin. They used it in the dose of 150 micrograms for body weight of less than 50 and 300 micrograms for a body weight of more than 50 kgs. And this is something that we used, and this is completion. You can see that desmopressin works very well in subcutaneous and in nasal routes. Medroxyprogesterone acetate, a favorite of many, but remember it is a glucocorticoid and can cause Cushing-like symptoms. I don't need to go into the details of the dosage. It has anti-androgenic properties, but long-term use like that of DMPA can cause a temporary bone loss. That's something need to inform your patients. It can cause, of course, minor headaches, and history of breast cancer and no evidence of current disease for the 5 years is contraindicated in patients with a breast cancer. Cyperatorin acetate, especially patients with hirsutism and acne, we use this drug, had a side effect of depression, B12 deficiency, stretch marks, twice the increased risk of DVT. So that's very, very important compared to LNG, hyperprolactinemia, meningioma, low aldosterone, hyponatremia, and hypokalemia. Norethistérone, our favorite, again, in cases of acne, hirsutism, voice changes, but it can cause a little weight gain. Gestodin, again, Mines, which was available, beneficial cardiovascular effects, no change in lipid profile, but 1.6 times high risk of DVT. So these are things that we need to remember. In the medical eligibility criteria, we love the WHO, all this has been mentioned. So we need to take a call. Obviously, you will not give this to a smoker or a diabetic or an obese woman. You need to be very careful. LNG intrauterine device or the LNG drug, it can cause any of these, right from breast discomfort, nipple discharge, increased hair growth, but the proportion of it is much less. So drospirenone, our favorite now, as far as ossicles are concerned, it is antigonadotrophic. It promotes salt and water excretion. It is effective against acne and hirsutism, increases HDL, reduces LDL, no androgenic side effects. In fact, it has anti-androgenic side effects, no anti-estrogenic side effects. It, in fact, reduces SHBG and does not increase free androsterone levels. And as a result of which, the acne and the hirsutism come down. However, twice a higher risk of DVT as compared to LNG. So this is something that we need to remember all the time. I cannot teach anybody anything, but I can only make you think. Now, let's go on to the next aspect. A long-acting reversible protein is something that is, again, for the asking, because patients in our country, at least, will not take oral hormones for a very long time. The main prevention of endometrial proliferation, it thickens the uterocervical fluid. It occasionally prevents ovulation and has hardly any foreign body effect. It releases about 20 micrograms of LNG. And that is why it is extremely useful in anemia, heavy menstrual bleeding, is an alternative to sterilization, endometrial protection, promising findings of treatment of endometriosis, endometrial protection in patients with tamoxifen. Long-term use of tamoxifen can cause a lot of problems like endometrial hyperplasia and cancer. The secret, if you want the LNG to work at least for 2 cycles, you'll have to consider no adverse effects on fertility, reversible. And we all know that the bleeding over the next 6 months to 1 year will reduce drastically in these patients. It is the first 3 to 4 to 6 months which are a little toxic when the patient is going to have a little bit of intermenstrual bleeding or prolonged spotting for a period of 6 to 10 days. And if you look at the cost of 5 years of OC pills versus an LNG uterine device, and we know that the LNG uterine device is very, very economical. We must not become Chidambarams of our patient or Nirmala Sitarams to say this product is very expensive. We know now with the DPSCA, the cost of the Mirena or the LNG intrauterine device has come down to less than 4,000. Works extremely well. We know that by the time 6 months pass, and if you can hold on the patient for about 6 months, the Mirena will probably do extremely well. Extremely efficient, good compliance, ensures contraception, does not impair future fertility, and definitely will reduce the risk of hysterectomy. There is a problem of irregular bleeding. We treat our patients with NSAIDs, tranexamic acid, and our favorite all-time is SERMs. We use ormeloxifene or Cevista twice a week in a patient who's got a very adenomyotic uterus for the first 6 months, twice a week for 3 months, and then once a week for 3 months from the beginning, from the time we insert the LNG-IUS. And most of them do extremely well with this. And these are some studies that say that it is cost-effective. Comparison of hysterectomy in patients waiting for hysterectomy versus TCRE, 50 women who were waiting for operation, bleeding reduced to accepted in 37 in 3 months, 4 in 6 to 9 months. 41 of them rejected surgery. This is a British Journal article. Similarly, I think the skill to perform TCR is gradually going down as compared to TCRE, the LNG-IUS is definitely equally or more effective. In fact, Dr. Nozer does a TCRE and then puts an LNG-IUS, but there are not many people who can do an effective TCRE now. The older generation can do it well. Hysterectomy, definitely, if a patient comes to me and says, I have 10,000 rupees, give me one procedure, I don't want to come back to you. I'm going to ask her to get a hysterectomy done. Otherwise, LNG would obviously be my first choice. Occipils and Mirena, I think the main problem is low compliance. Patients forget. I have a lot of patients who are air hostesses who say that I don't know which is night, which is day when I'm traveling international. And that is when I think the LNG-IUS works very well. Our favorite for these air hostesses used to be the Newer ring. Unfortunately, it's not available in our country now. Adenomyosis definitely works. I can show you some pics. Fibroids, type 4, 5, and 6 fibroids with heavy menstrual bleeding, I would put in just an LNG-IUS. It works extremely well with endometrial suppression. And gynecological indications, probably the most effective conservative form of heavy menstrual bleeding. It is the gynecologist who has to be convinced, not, I think most experienced gynecologists will be able to counsel and convince their patients very easily. Improvement of the PMT syndrome, a role in treating endometrial hyperplasia and polyps, shrinkage of intramural fibroids, provides progesterone opposition to systemic estrogen in HRT. With systemic estrogen, no lead HRT regime. If I have a patient who needs hormone replacement therapy and I have this, I may have to give her progesterone for at least 10 to 12 days in a month. Most of these women don't need bleeding. So either they could be on 2 or 5 milligrams of MPA or norethistérone, or I think the LNG-IUS is the best option. Weight options, I don't think there is much weight gain in these patients. In finale, GnRH analogs only short-term have cost compromises fertility. I think LNG probably is the best in a patient who wishes to conserve her uterus and wants a versatile for heavy bleeding. Long-term effect, safe, value for money, non-surgical, prevents fertility, amenorrhea with increasing time. This is a paper we have just published in the FIGO conference in Paris, which was accepted 125 patients. Another paper of 100 patients. We totally have finished about 450 patients. We have a success rate of 4%. Time changes everything except something within us, which is always surprised by change. I think there is a lot of resistance on part of the gynecologist to accept LNG-IUS. And I think once the gynecologist is convinced, the patients will easily accept it. Possibilities are endless. The only thing is you should know where to look. I think our approach must be patient-centric. And if it is patient-centric, I'm sure at least 7 or 10 times we'll be able to conserve the uterus on our patients. If I have time, I'm going to show you a few pictures. This is a patient of ours, again, 5 years LNG. So knowledge needs to know how the LNG is to be identified. It doesn't give an echogenic shadow. It gives an echo-poor shadow. This is the ideal way of looking at the LNG-IUS. That's another patient with LNG-IUS. And you can see here severe adenomyosis in patients who came to us with pain and heavy menstrual bleeding. After the LNG-IUS, 1 year later, you can see that the posterior wall has probably become as much as the anterior or maybe just a little more. Patient is happy. We are happy. And this expert review on adenomyosis also says that, of course, hysterectomy is the final choice. The definitive treatment for adenomyosis is hysterectomy. But initially, less invasive approaches should be tried, including occipitals, progestogens, danazol, gonadotrophins, LNG-IUS, myometrial excision, and uterine artery embolization. Another lady here, 33 years of age, P1L1, CA125, 126. You can see here a large adenomyoma. Again, on the MRI, you can see a large adenomyoma. And she did extremely well with the LNG-IUS. Another woman, age 40, with a small fibroid, 40 years of age, 6 grams hemoglobin, did extremely well with the LNG-IUS. You don't even need to go and remove those fibroids. Polyp, of course, can recur. We know that. In a polyp, I think an LNG-IUS would work wonders. Patient of arthritis, you can see, can't even fold her legs. Now, she's a patient of osteoarthritis. The US uterus was 10 into 5 centimeters. Adenics are normal, 50 years of age. The LNG did well. We were a part of the FOGSI study on heavy menstrual bleeding, the GCPR that came in, and we were a part of it, and adenomyosis, which what my forte was. And this is the palm coin algorithm as to how do you manage the AUB in a patient. It's a very crowded slide, and I'm sure you look up the net. One more time, possibilities. The only thing is you should know where to look. Thank you very much for the patient hearing.
Thank you very
Thank you,
much,
sir.
Atul Ganatra. We really enjoyed your talk and the sayings that you sprayed it with intermediately. So it was very clearly explained. I think we could start off directly with the questions, answers. We've been getting a few questions from the audience, and I think all the speakers are here. Dr. Saurabh Dani, would you like to continue the question that I asked you before this talk, and would you like to complete the answer to that?
Yeah, so I'd already answered about what antenatal test, that is GPCR guidelines from FOGSI. So I think best is to visit the FOGSI website and get the latest guidelines coming from there. As far as newborn screening is concerned, as I just mentioned in my PowerPoint, I think the basic thing that we need to do about is thyroid, CAH, that is congenital adrenal hyperplasia, G6PD, hemoglobinopathies, and a hearing screening. So this would be the absolutely basic thing that any newborn should be getting once they deliver in a healthcare facility. And beyond that is all regional and specific, depending on the affordability and the regional incidences.
Sure. Thank you very much. I think the remaining questions are all for uterine bleeding. So, Dr. Atul, I hope you're around. So there is a person who's asked, Dr. Donna Susan, and asked this question. It is in two parts. The first part is one, managing AUB in patients on warfarin, and two is puberty menorrhagia drugs in girls 10 to 11 years of age. Can these little kids be given hormone therapy? If yes, what are the options?
So first of all, as far as warfarin and clopidogrel is concerned, we have a huge experience of these patients. And very often, if you see that the cardiologist or the cardiac surgeon wants to keep their INR about 2.5. And if they keep their INR about 2.5, no amount of hormonal medication is going to work. We can give them very high doses of norethisterone or medroxyprogesterone acetate. But remember, when you do that, the subsequent cycle, she breeds more. So these patients ideally are for LNG-IUS, wherein you would tell them that add-back therapy of heparin in LMWH, reduce the clopidogrel or the warfarin, bring the INR down a little bit. They are a little unhappy with adequate enough that you can perform the short procedure. And then we give them, put a Marina into them, an LNG-IUS into them, give additional SERMs, that is ormeloxifene. For the next 3 to 6 months, they will have amenorrhea with that, and then gradually the uterus accepts it very well. Of course, if a patient is fed up, she says, I'm fed up, my hemoglobin is 5 grams, and she's tried everything else before she's come to you, and then hysterectomy is the second choice of option. But we are very, very vocal about using LNG-IUS. Sometimes you get a 32-year-old woman. I had a Marwadi woman who was 32 years of age, who had a CABG plus valve replacement and had an INR of 2.8. So we did counsel her for LNG-IUS. She did insert it for the first 5 years, but subsequently she said, ab mujhe uterus nahi chahiye, mujhe bacche ho gaye. But we've had about 11 patients who had 2 insertions, 4 patients for 3 insertions. 3 previous LS, 32 years of age, comes to me still. She's got the 3rd insertion now, and about 458 patients who had a single insertion. And now, of course, the guidelines have clearly said you can use it up to 7 years. You don't have to remove it. So we do ultrasound, and if we feel on ultrasound that the Mirena looks okay, the LNG-IUS looks okay, we just continue for another 2 years. And in young adults, I mean, that's a huge problem between 7 and 14 or 7 and 16 years of age. My youngest patient, I told you, was 7 years of age. I put her on tranexamic acid. It wouldn't work. Ultimately, I had to give her norethisterone acetate. We tried MPA, it didn't work, but I had to give her norethisterone acetate. She had already taken Aquaviron from another gynecologist and come. And I think very, very apprehensively, we know that if you use a lot of hormones, the epiphysis will close faster. but I don't think we have a choice if she's 4 grams hemoglobin. We use, depending upon the BMI, we start with a dose between 2.5 to 10 milligrams and then gradually tide over the crisis. I can't put them on OC pills because if she forget, she's going to have a problem. And here the counseling is that of the mother. We need to tell her that it is your job to remember. I know 2 or 3 mothers who came and told me, मैंने उसको बोला था दवाई time पे ले लो. That 7-year-old child is never going to remember to take these pills. Yeah. So I tell my children, please tie the tablet to your toothbrush. So when you wake up in the morning, you'll remember that ye goli lena hai. At least I'm sure they will be brushing their teeth once or twice a day. And I think the mother needs to be given a lot of counseling. These days, mothers have their own kitty parties and their own, OTTs to watch, and the kids are left in the lurch. But I think major counseling is to be done from the mother's side.
Sure. Thank you very much for that. Yeah.
Just last warning that I wanted. I have about 11 patients who come to me with cavernous sinus thrombosis. One of them was my own resident in Fortis who was taking OC pills for PCOS. But we must be writing 1 OC pill every day to a patient. That's why I say all medicines are safe. Some women are dangerous. We need to identify these women. And that's why that stamp of mine works well. We tell our patients, please, if you have any of these symptoms, report to us immediately.
Sure. Okay, I'll go to the next question, and I can see there will be some overlaps in the questions. Next question is, what is the medical management for cardiac patients, rheumatic heart disease?
Again, LNGIUS. It doesn't give infection. Progesterone makes the cervical mucus thick. I think undergraduate teaching. And my first choice is always going to be LNGIUS. I would give them a trial of oral hormones. And I'll tell them, see, the oral hormones are working, but the oral hormone has to go from your stomach to the liver, liver to the blood, blood to the uterus. Instead, just get something inserted directly inside the uterus, and it will work very well. Our problem is the seasonal one. मेरे से पूजा नहीं होती है, मुझे spotting होता है. I have this function, I have that function. That is a usual problem. And that's why we are very aggressive in using or meloxifene or Cevista for all these patients when we put them there on the LNGIUS.
Can LNGIUS be used if the size of the uterus is around 14 weeks?
Yes, what I would do if the patient is 14 week size, I would put the LNGIUS and give 2 doses of Zoladex to her. Give 3 doses of GnRH agonist, bring the uterus size down. Monitor that by ultrasound.
Sure. Is Dynogest really helpful in endometriosis, as like many gynecologists use as first-line treatment management?
Is this for me or Aditi?
I think she's left.
Okay. So I think I'm a great fan. I have about 16 or 17 patients who are less than 20 years of age have endometriosis. Pelvic pain, you can't do PVs on them, not sexually active. Small endometriomas, maybe 1 or 2, or maybe just in adhesions, or we do a PR on these patients. They have a high CA125, and I'm going to be giving them a Dynogest for sure. Because even after you finish doing the surgery, you could do a level 3 surgery also. I have seen lots of recurrences. My surgery should be the best surgery, and after that surgery, the patient should be able to conceive. I tell my patients the best treatment is pregnancy. Amenorrhea in the form of pregnancy, tablets, injections, breastfeeding. And I made that mistake and told one of my patients that after surgery, I told her, your best treatment is amenorrhea, and the best way to get amenorrhea is pregnancy. And she actually became pregnant. So I asked her, when did you get married? She said, you never asked me to get married. You told me to get pregnant, so I've got pregnant. And she actually got married in the 7th month of pregnancy. I think counseling is very important. So we have more than 86
because people take
patients
such obvious.
Yeah.
Use with COC better to prevent further process. Sorry, that's all.
Sorry?
I'm just reading it as it is.
I think that's just a comment.
Okay. Fine, I'll go to the next. AUB for 3 months following delivery, USD found to be normal. What to do?
Give tranexamic acid. Remember, these patients have subnormal estrogen progesterone levels because they are breastfeeding. Their estrogen progesterone levels are going to be low. Talk to her about progesterone only pills. Give tranexamic acid. If that works, continue. Otherwise, progesterone only pills or LNGI will essentially work as contraceptive as well.
Sir, please tell dose and duration of ormeloxifene.
It's 60 milligrams twice a week for 3 months, followed by 60 milligrams once a week for another 3 months.
Yeah, I hope the one who's asked the question has made a note of that. Can ormeloxifene be used in young girls?
I would be a little careful in using them in young girls. That will be my last resort.
Sure.
Because they will forget.
Yeah.
They
Sorry?
will forget. It's a week pill. They don't remember daily pills. हफ्ते का दो तो alarm रखेंगे तो भी भूल जाएंगे, I think. And of course, it is not indicated in, young girls in the teenage group.
Practically, till what age can we use OCP for AUB management in patients with low proneness for complications?
You can use it for as long as you want. I know of women who've been taking it for 10 and 15 years. As long as they monitor their breast, their ultrasound, and they don't have any problem of DVT, they can go on. 44 million in Europe use OC pills. All these women who are perimenopausal, like Oprah Winfrey, how do you think they look young at all times? Half of the Europe is on OC pills, half of China is on OC pills, and half of China is on IUCDs.
Are there any more questions, conference team? That's all I thought. Yeah. So it was really enlightening and really learning lesson. Thank you so much for all the speakers and the chairpersons. I would like to share with you all that for this conference, we got almost 1,400 registrations. And even till now, there are more than 320 people live online attending it. So this is really, the entire credit for this goes to the speakers, the topics, and how well they've spoken on that. Just one last bit about ISPAT, and if you could show that, we, as I've mentioned earlier, ISPAT organization since 1989. Our, our reach, our motto is preconceptional, prenatal, and postnatal or neonatal. We cover the entire spectrum, pre-pregnancy, during pregnancy, and post-delivery. And that is the reason why we are into all these academic activities. I urge you all, those who are not yet members, please become a member of ISPAT. There is a very nominal life membership fee, which gives you access to all our conferences. We have an annual conference, a biennial, and we have several CMEs and other trainings and activities throughout the year. So to sum it up, is there anything remaining on Aditi?
No,
Otherwise, I'd like to close with warm vote of thanks to the all the speakers who have actually taken out time from their hectic schedule. Dr. Atul Ganatra, Dr. Aditi Dani, Dr. Sudha Tandon, Dr. Saurabh Dani, for being here with us and enlightening us with all your interesting topics. Thank you to the chairpersons, Dr. Jyoti Saigaonkar, Dr. Varsha Lahade, Dr. Jyoti Bobe. I realize a few of them have left as they had flights to catch or another surgical appointment as well. Thank you to our academic partners, without which this would not have been possible. Thank you to the conference team for conducting it all so beautifully well. Over to you, Aditi. And Dr. Saurabh Dani, the president of ISPAT, and also the ICOG team. So, they are the ones who have conducted this entire show. Aditi?
Thank you, ma'am.
Thank you to all the audience for active support and participation. Goodbye, everyone.